I think one of the inspiring things about this conference most recently has actually been the development of carrier sessions, so that the carrier population have really started to have a voice and to identify and communicate with one another and go through all their problems. So it's a real pleasure to actually introduce Cynthia James, who is the Assistant Professor of Medicine at the Center for Inherited Heart Disease at Johns Hopkins, to talk to us on how do women adapt to being a Barth syndrome carrier. And the rest of it is up there. Thank you very much for coming.
All right. Thank you all, and thank you, Colin, for that nice introduction. I am thrilled to be here with you this morning to share the progress in our research study investigating how women adapt to being a Barth syndrome carrier. This is something completely different, I think, for many of you in the audience. This is a mixed methods study of psychological adjustment and reproductive options. As Colin mentioned, I am a geneticist and genetic counselor working at Johns Hopkins in the Center for Inherited Heart Disease. This is my first time here at the Barth Syndrome Conference. Before I want to go any further, I want to say just how impressed I am by this organization. I've worked in genetics in some way, shape, or form for the better part of 20 years, and what I'm seeing here is almost unparalleled, so congratulations to all of you. So this study, as Colin indicated, grew out of the Barth Syndrome Foundation community itself. Becky McClellan is a close colleague of mine, and as I understand it from her and from many of you I've had the chance to chat with over the last couple days, the carrier sessions were first established in 2014, at which point the leadership of your community realized that more attention to addressing the psychological concerns, reproductive implications, and ways to support women and girls who are or may be carriers was needed. In genetics on the whole, this is a fairly understudied area. There has been some research on the impact of being a carrier of X-linked and other diseases. How families make reproductive decisions and work with emerging genetic technologies and reproductive options is not all that well studied, at least in this country. That's a very politicized issue. The NIH is, as you might guess, not eager to fund those sorts of studies. And so because of that, the foundation put out a request for applications specifically on the impact of testing positive as a Barth syndrome carrier. This is just a quick background, what we do know from the literature. So studies have certainly shown, and I think many of you have experienced this, that X-linked inheritance tends to promote guilt among mothers, feeling blamed in some cases by partners, and there's even a study I did on conditions in the past where in comparison to other forms of inherited disease, this guilt-blame dynamic between partners is particularly likely. Some studies have indicated the possibility of stigma among younger girls, younger women in families as they're developing romantic relationships and dating and needing to disclose carrier status. And there's also impacts on families as sisters are or are not carriers, and so on. So there's reproductive challenges, of course, that come along with being carriers as well. This decision-making process can be, but is not always, ethically complex for families, and we're living in an area of rapidly expanding reproductive choices. So, with the impetus of the RFA and my co-investigator Becky's long experience with the foundation, we developed a study with the overall objective of characterizing the nature, frequency, severity, and predictors of psychological and reproductive challenges. With our overall goal was to provide an evidence base for improving services for carriers. And something I've chatted about as well, for this community, with all the success of all of you who are developing research and treating boys and men, the next generation, as men grow up, have daughters, all those daughters, of course, will be carriers. So for this community, I think this is a growing population who will need to be served. All right, so this is a mixed methods study. So it's a mixture of a qualitative study first, using data derived from a qualitative study to do quantitative measures. So aim one, semi-structured telephone interviews of adult carriers, in which we did qualitative analysis. So the idea is you explore experiences and develop hypotheses. Aim two then is a questionnaire for all adult women in Barth families, both women who are carriers and women who are not carriers, because we're trying to decouple the implications of carrier status from simply the implications of being in a family with a member with Barth syndrome. That's going to be analyzed quantitatively, and the idea here is to test hypotheses. Most of what I'll talk to you about today is AIM-1, the qualitative study, because that's where we're at in terms of research. So again, identify and describe common psychological challenges, AIM-1A. B is to describe attitudes towards and decisions with reproductive decision making. And our third aim focused on how women derive support from other carriers, both within families and through the foundation. AIM-2 we'll talk about later. Again, that's the quantitative aim. We're going to measure via questionnaires. All right, so the qualitative study. This was adult carriers recruited through the Barth Syndrome Foundation. A genetic counselor, not known to the families, but experienced with inherited heart disease, interviewed participants. The interviews were audio recorded and transcribed, and we did standard qualitative analysis. I'm happy to answer questions about that later. All right, so right now we've conducted 28 interviews. We were successful in getting a fairly wide range of ages, although almost half of women interviewed were between 30 and 40. Half of women were American. Another third were from other English-speaking countries, and there were 5 very brave women who were kind enough to participate in this telephone interview with a stranger in their second language. I'm really grateful to them. Most people interviewed were raising minor children at this point. And our interviewees were predominantly mothers, although we had a decent number of sisters and a few aunts and grandmothers as well. And then 5 women were both sisters and mothers of affected individuals. So all women, by study design, knew their carrier status, either through carrier testing or because they were an obligate carrier based on the family pedigree. So about half of women learned their carrier status while they were family building. And then we had a group that had had carrier testing before making any reproductive decisions. One thing I want to point out that we learned, and I think it makes sense, is for most of the women we talked to, carrier testing was sort of fait accompli. There was no long decision-making process. It tended to happen as part of diagnosis. So this woman says, well, I think she, the geneticist, would have given me the choice to say no, but she kind of said, hey, you probably want to know if you're a carrier. And I thought, oh, well, yes, absolutely. Or an obvious step in planning a pregnancy. And I know Becky here works very hard with young women and girls in the community to start talking about this process, but it's far from universal. And as I think many of you knew, guilt was the most common psychological challenge faced by most mothers and grandmothers, but it was not universal. And this wasn't due to a lack of knowledge or a lack of understanding of inheritance. This was, as this woman says, the rational part of me knows there's no sense in it, but I think the emotional part still feels guilty. And I know if I find out that if my daughter's a carrier, there'll be an element of guilt there, I'm sure. Although for other women, this really wasn't that salient of an issue. She says, well, I don't feel guilty about it because it's not something you can control. All right, as I mentioned before, most of the women in our study had either made or were actively making reproductive choices, knowing they had a chance of having an affected boy. And this was a challenging situation for most families, and the challenges came in 4 areas. For some, there was a lack of information and knowledge about available options. And then there was also this issue that for quite a few had experienced this dynamic of getting too much information too soon when they couldn't process it. There were a fair number of interviews where women describe receiving the diagnosis, their son being hospitalized, and then somebody popping into the hospital room and giving details of reproductive options for the future. And people were kind of like, hey, I've got a son I'm trying to, is in heart failure, and why are you giving me this information? So the right information at the right time was a challenge for quite a few. Even for people who knew about prenatal diagnosis options, there was issues of location, even if you knew about it, but it was hundreds of miles from your home. That wasn't going to do you any good. There were, particularly in this country, financial implications. And for some of our women from other countries, there was an issue of a waiting list. There was a woman who said, well, you know, that's a good option, but I have to wait for 3 years in order for my time to come up to be eligible. And, you know, I'm in my late 30s already. Is that really going to work? There was challenges of support. This was a difficult decision to talk about both within the community and outside the community, and for many it was complex decision making. This woman says, gosh, I really wondered if or not our marriage was going to take it. I felt really let down by the medical profession that they didn't consider a genetic cause before, and then she was pregnant and needed to make a decision. But not all. Again, there's nothing universal in this disease. This woman says, I honestly say it wasn't a very hard choice for us. So within the carriers we talked to, there were starkly different views about choices for family building or not, both between families and within families. There were differences as women developed ideas over time, made different choices from one pregnancy to another. And there was a significant theme of there being a difference between generations. Sisters, and again, the numbers were small. This is a qualitative analysis. Sisters were more open, on the whole, and more enthusiastic than mothers about considering implantation and prenatal diagnosis. And this woman says herself, well, I think if you're someone in my generation, well, like me at least, I think it's a bit of an easier decision because there's no kid to explain why you're doing what you're doing. For many women we talked to, and these are long quotes, but I could easily have put 20 quotes on these themes up on the slide. This was a prolonged and morally complex decision. The women we heard from really struggled with loving their sons so much, and the challenge of making a decision to not choose or eventually discard an embryo, people likened to their sons, was very hard. So this lady says, am I saying a boy's not good enough? Am I saying I just want a daughter? Am I saying that another child like her son, no, 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 I don't want that? It was quite horrible, actually, for me and my husband. It wasn't nice, because it was almost as if he was saying, what we have, let's see what else we can get. And this was a theme we heard from many, many mothers. All right, moving on to the third aim of this study, where did women get support in general? We heard glowing things about the BSF community, and now that I'm here today, I can see why. People did get support from family, health professionals, and then clergy or church. And for none of these was support all simple and good all the time. There were good and bad of all these things. As I think you all know, there was strong positive support from the community regarding the medical and practical aspects of Barth syndrome. There was also really positive things most women said about receiving emotional support from other carriers. So that issue of guilt and distress associated with carrier status, many women said was really ameliorated via interactions with other carriers, and that's via normalization. I'm not the only one out there. I'm hearing this from others. So this first woman says, well, talking with some other carriers helped a lot. Just hearing other people experienced carrier guilt, because there really isn't anything online about it. I was surprised. At first I thought it was maybe something I made up, like I'm a carrier and I'm guilty. It must be carrier guilt. But at the last conference, it became a big topic, and it was helpful and well-timed, because I started to feel a little bit better and to have all these people say they'd gone through the same thing. And so that's something I think the Carrier Services program here has been very helpful in. Quite frankly, a few women, said, hey, I don't need carrier support. Maybe my situation's different because I'm on the older end. This isn't a salient issue for some. Probably the biggest challenge we heard from women was receiving support or navigating the BSF community and reproductive decision making. So despite the strong need acknowledged for many for support sorting through these reproductive options, most were wary about discussing this with other carriers. A few had ventured out there and found it helpful. And And women were really very careful in this. Nearly everybody stressed that their own choices should not be normative for others. So this lady says, well, I'm pro-choice for other women. That's a personal decision and it doesn't bother me. Another one says, well, I don't disagree with anybody. It's a very hard decision to make. Regardless of what you come to, it's hard to even get there. Many also really feared damaging highly valued relationships by broaching these political and potentially and highly personal topics. So this woman says to us, I am worried about the group kind of splitting. Like, okay, here's the people who are totally for technology and maybe would end a pregnancy and they're doing anything they can to have a child without Barth. And then we've got a very strong group who believes it's God's will, and if that's what he's going to give me, he's going to give me. And so it's unique. And certainly that's a very good summary of the rationale we heard from people as well. And why is this so difficult? Well, because of course these are really personal, deeply felt decisions. So, you know, this lady says, well, everybody's in it, so nobody can be objective about it, and everybody's got a different experience as well. And another lady says, well, I don't think it's hard because we have different concerns. I think it's hard because it's so personal, and so on. We mentioned that a lot of people got support from families, but that was not simple as well in this reproductive realm. We uncovered a theme of so in genetics, there's this concept of survivor guilt. You inherit a mutation and your sister doesn't. Your mother has a mutation and her sister doesn't, and so on. This is a sense of survivor guilt related to timing. So remember, we only interviewed carriers. But this woman says, well, I felt really guilty because I couldn't tell my sister, oh, I'm happy that I can do something, and I'm happy we saw this before my pregnancy that I was a carrier. So this is a woman who pursued pre-implantation genetic diagnosis. And then she wasn't aware of it, but it was a chance for me. And there really were generational differences. Because this wasn't available to some of the mothers and grandmothers, some of whom were quite relieved by the fact that they hadn't had to wrangle with this decision. Really, the generational changes, the changes in technology have made getting support across the generations somewhat challenging. So what are the implications for this community? Certainly, what we've heard is a lot coming from the Emerging Carrier Support Services program has been helpful. In regards of reproductive decision making, there's probably an avenue for smaller subgroups, smaller mentoring. And I also wanted to say that navigating these personal and potentially political options, I think is a challenge not just for this community, but as patient and family support groups increase in prominence for genetic conditions, not only in providing support, but in caring, but in setting the research agenda, funding the research agenda, gathering scientists like we're doing here today. Meeting all those needs, I think, is complex. So I've been in genetics in some way, shape, or form for almost 20 years. And when I started, support groups tended to just do support, and they tended to be subgroups broken down based on things like this, based on how you might make reproductive decisions. I don't think we should go back to the old days, but I do think this is an increasing challenge for these growing communities to navigate. All right, so what next? We're using some of this data and have developed a questionnaire to measure the frequency and severity of psychological challenges, to test hypotheses about which carriers are most likely to have significant adaptation difficulties, and to test hypotheses to determine the mechanism by which interactions with other carriers influence psychological outcomes. Oops, sorry. I can talk about this later. This is an adjustment model that we're using to help organize variables we're collecting in the questionnaire. This is a fairly standard adaptation model. We chose it because it highlights both risk factors relevant to this disease as well as resistance factors that modulate adaptation outcomes. I am very happy to talk about the details of this with anyone who's interested. These are just some of the hypotheses to be tested. And so I will wrap up the talk by making a call out for, I'm now calling all adult female relatives for the second phase of this study we're calling the female side of Barth. This is an online questionnaire that we will have available end of August, beginning of September. We would ask interested people to sign up with us today. We'll also, after the conference, work to advertise it for study launch at the end of the summer. But if anyone's here now, again, I can take sign-ups for that today. We're also asking adult men to participate in a shorter questionnaire. As we talked about before, of course, all female children of men with Barth syndrome will be carriers, and we just want to get a snapshot of their perspective on that. So again, taking sign-ups today for that. And finally, I'd like to acknowledge, first of all, the foundation for the opportunity to do this study and the opportunity to get to know all of you as a community, as well as my colleagues, Becky McClellan, who is the woman who let me know about this study and has been my partner in crime as we've done this, as well as Layla Jamal, who is a genetic counselor who conducted all the study interviews. So thank you all. I'm happy to take any questions, and I'm happy to chat with anyone later.
Thank you, Cynthia. Sounds as though the findings that you got were just about as variable as my findings.
Yes, pretty much. Actually, as you said that, I was laughing. I'm like, yep, I'm about to say the same thing.
Sure. Hi. I have a question about the carrier situation, because in Barth's case, this is X-linked.
Correct.
So I think most people not appreciate the difference between a carrier of X-linked disease and autosomal disease, because they also have the terminology that say a recessive X-linked. I don't think you have a recessive X-linked, because each cell is only expressed one X chromosome, even in a person, right? Because female human are mosaics.
Correct.
Although they have two X chromosomes, one is inactivated.
Correct.
So depending on the inactivation, certain cell will have a Barth chromosome expressed, a certain cell will have a normal chromosome expressed. So you don't have a really like autosomal recessive kind of a situation. So my question is it any studies of carrier, do they really don't have any symptoms? Because I talked to some mothers of carriers, they notice their daughters have some sensory deficiency or some sort of very related to the Barth boys, like a craving for salt or vinegar, kind of a...
Yeah, that's an interesting question. So more broadly, in genetics, with many of those X-linked diseases, you summarized it perfectly, we have learned that often women have, or a subset of women have a milder phenotype. I do not think there's, although you guys would know better than me, to the best of my understanding, there has been no rigorous study of that here, but we haven't, certainly it's not the situation of something like Fragile X syndrome or Duchenne muscular dystrophy, where there's a very clear, mild phenotype in some women. I have not seen or heard of any of that. It's a great question, though.
So I have a related question.
Sure.
So for any detrimental mutation genes to be passed on from generation to generation, sometimes because it offers a competitive advantage, like sickle cell anemia. Yeah. So because of a small population, I'm not just wondering whether if you investigate ancestral survival, whatever background, you could gather some information about competitive advantage of pass on this mutant in the population.
Yeah, no, that's an interesting question. I would like, so in terms of population genetics, important to keep in mind that I think the new mutation rate of Barth syndrome is fairly high. So there is by definition, that means there's a fairly negative, there's a high negative selection pressure. So I work with families with other kinds of inherited disease, inherited heart disease, and we've never, literally never seen a new mutation, which has, of course, different implications for the selection pressure against it. So I think it's possible there's a competitive advantage, but I would keep in mind the very high new mutation rate when you think about that.
Do you think you need a normal control also?
A normal control, like in the questionnaire part of the study?
In the second aim, yes.
So there's two ways to answer that question. So first of all, and I didn't go into this in detail due to the audience, so we're using standardized psychological scales. And so there are inherently normal control data because they're standardized scales. So one outcome is, anxiety and depression, using the hospital anxiety and depression questionnaire. that's been used for 35 years, and there's all sorts of normal data. So, but I think what we do need is we need women in families with Barth syndrome who are not themselves carriers. They're not normal controls, but that helps you sort out the effect of being a carrier from simply being part of a family with Barth syndrome, if that makes sense.
So I know that there is no registry of stillborn babies with Barth syndrome in the United States.
No, I don't think so.
Is there something like that anywhere else? And given that this is Mendelian distribution, so to speak, what is the expected frequency and how far are we with the known cases versus potentially unknown to us cases?
Oh, that's an excellent question. And so, no, I'm quite, all right, so that goes to if you have, you know, a stillborn baby or even, you know, a baby dying of SIDS. In the other part of my life, there's an increased push to do molecular autopsies in those situations. No, there is no registry, and in fact, molecular autopsies, molecular genetic autopsies are just coming. I think that would be the way to get a sense of that. If you see a mutation, you would be able to get the mutation rate and the likelihood of picking that up. I don't think we have data on that. You all may have better data coming out of the UK. I know you've got a big initiative doing those molecular autopsies, but I don't know that data off the top of my head.
I think stillbirth had affected, I think, 3 of 19 families at the time that we studied and published a paper some years back. And actually, since then, we've never discovered, from looking at quite a lot of stillbirths where there was cardiomyopathy or hydrops, we've never discovered another case, actually, which has been a big surprise to me. One last brief question, and I think we must move on.
Hi, so I'm a geneticist from Children's Hospital of Philadelphia, Marnie Falk. I was really curious by your comment that there's a very high de novo mutation rate, so you would expect an X-linked disease to have about 1/3 new mutations. In one of the reports that the doctor from Florence, I know she's here, presented on her poster last night, she had 11 cases over the last, I don't know, 10 or 15 years, and only 1 was de novo.
Oh, really?
So she had the
That's
impression that
interesting.
there was a reduced de novo rate in this disease. So I was curious where your knowledge comes from of that, because that's, to me, critically
Right.
interesting, you know, that fact.
I mean, this is honestly just the Kennedy-Krieger data based on clinical experience, and it was, I mean, it was about 1/3, although you expect a one, well, we can talk about this later. I think you'd expect a 1/3 de novo mutation rate if the selection pressure against is very high, right? So.
And nobody's done prevalence studies, like nobody's looked at the incidence in all newborns, you know, 5,000 consecutive newborns of this.
Right. No, I mean, yeah, again, wouldn't that be amazing? And I bet that data is going to come because you know there's these large studies, these large whole exome studies enrolling children, newborns. I mean, there's a big study out of Fairfax. So that data is going to exist if we all go after it. Yeah.
Okay, I do have a quick comment.
Sure.
On the Barth variant database, I note all the cases that I know are de novo, but I do not know how many parents have been tested.
Okay. Thank you. I think we must
right.
move on, but thank you,
Thank you.
Cynthia.